So just kind of like, to specialize like, in kids with chronic conditions. So, in general, the incidence of diabetes has definitely been on the rise for a while. So definitely wanted to specialize on that, both in terms of type 1 as well as type 2. And also like, other conditions that we see in endocrine or like autoimmune conditions like thyroid disorders, celiac, and we see a lot of bone disorders as well, like vitamin D deficiency. So just in general, like, focusing on children with chronic conditions. It's definitely something exciting about this field. So one thing, like, with diabetes and technology, like the last couple of years, it's definitely, like compared to the past with insulin, the shots and the pens and things like that, we do have more insulin pumps. So something like, kind of attached to the skin. So people really don't have to give themselves so many shots throughout the day. So definitely insulin pumps, even glucose sensors, which are attached. People can, avoid finger pricks and can kind of like, have their glucose readings pretty much like, delivered automatically. And also, there've definitely been more like, medications for weight loss. Now, a lot of times, like, when we prescribe these medications, we tell people that they're not, obviously we have to combine that with diet and exercise. There's really no magic weight loss pill, but definitely with like medications like metformin, even GLP analogs like Ozempic and Wegovy, things like that, they've definitely helped in the care of diabetes as well as to lose weight in general. Like, there's definitely more of a genetic component, not just for diabetes, but other disorders that can cause weight gain as well. So, a lot of times, like, we assume that someone, a lot of times, like with obesity and weight gain, it's just from not going outside and eating junk food and just not eating well. But especially with COVID and the pandemic the last couple of years, it's really been hard for people to get outside and exercise. We've definitely seen a lot of weight gain, a lot of diabetes the last couple of years, but there's definitely more of a genetic component, like more so for type 2, which we've seen. Patients where their mothers have had gestational diabetes during their pregnancy are definitely at higher risk. And we've also seen other genetic syndromes where, regardless of diet and exercise, people just don't feel full and they're going to continue to gain weight. So I feel like a lot of times when the weight gain is very rapid, we do a lot of genetic testing to see if there's something in the genes. It's definitely like, good for weight management, but we often tell people it's not a magic weight loss pill. So we do tell people, like, if it's not combined with diet and exercise, we have a lot of patients that lose weight, but in spite of being on Ozempic, I have a lot of patients who gain weight. So, a lot of times, like, they just get very lackadaisical and they think, oh, I could give myself the shot and then eat whatever I want and then not exercise and then it's going to lose weight by magic. So we do tell people that it's really to kind of help secrete insulin from the pancreas and kind of either prevent diabetes or suppress the insulin levels, but by itself, it's not going to help someone lose weight. So really have to combine that with playing sports or going to the gym, definitely cutting out juices and sodas and cookies and chips and more fruits and vegetables and more protein. But definitely with the combination of diet and exercise with Ozempic is the optimal management. Yeah, I think the family is the most important thing because I feel like, a lot of times, and oftentimes, like, we have parents and they go, a lot of times, like, the kids will see cookies and chips and snacks at their friends' houses. And then, like, the first thing the parents will be like, well, I don't really buy that. But then if they go to a relative or they go to the friend, they eat that there. So I think the family involvement is probably the most important thing in pediatrics because obviously an 8 or 9 year old is not going to understand the concept of diabetes like 30, 40 years down the line until that child has to take medicines and give themselves shots and things like that. So they don't really understand the concept of diabetes. So I think the family involvement, not just the parents, but other siblings in the house, if they live with grandparents, I think the extended family is probably the most important part, especially within the pediatric world. Yeah, so a lot of times, like, when we see the child, obviously, like, we ask, now, a lot of times it's kind of hard because if both parents are working, a lot of times, like, we have to see the child with a babysitter or a grandparent, uncle, aunt, whoever brings the child. So, but we do tell them, like, we try our best to have both parents involved, and especially everyone with the family. Especially if, the child is on summer vacation, if the visit, say is in July or August compared to, like, this time of the year when the kids are in school. So we definitely have to, we try our best to get both parents involved for the actual visit, and we do diet counseling for everybody. And oftentimes, like, when there's a strong family history of diabetes, a lot of times one of the parents has diabetes, and, like, themselves. A lot of times, any counseling I do for the child can help the parents as well. I think absolutely. I feel like, especially, like, just in terms of diabetes, like, obviously with the glucose sensors we have without pricking or checking the finger sticks, we pretty much have glucose readings every 5 minutes. And I myself, like, being an endocrinologist, can actually download the apps to my phone, so I can actually check the glucose reading of any patient. So a lot of times, like, and we do a lot of telehealth. We do a lot of virtual visits ourselves. So I feel like, that it's really good for patients because they don't have to go to the doctor at every visit. That a lot of times, like, they can just be managed over the phone, and as long as, like, a doctor, or even a lot of times, like, not just a doctor, like, I know a lot of people who do telehealth health visits with a nutritionist, a dietitian. A lot of times they don't even have to see an endocrinologist. So whoever the practitioner is, as long as, like, they're in front of the computer, they have apps, I feel telehealth visits have really improved and definitely made it more personal, as you said. It's definitely challenging because, like, obviously, like, they're in multiple environments at the same time. So a lot of times, the thing is, like, we tell, the parents say, all right, like, we make sure that our child eats healthy at home, but as soon as, they leave the house, we have no control. Obviously, if they go to a friend's house, a relative's house, things like that. And one thing we're trying to work with schools also, this is something the last couple of years, unfortunately, to kind of cut costs. We know that some of the unhealthy foods are less expensive. So, especially in schools, the quantity of unhealthy food is definitely going up. So, whether it's vending machines, whether it's chips and things like that, we tell people a lot of times, like, you can buy a bag of potato chips for $1 from the vending machine. So, a lot of times, we're trying to discuss, and we've had actual lectures with schools, whether it's the school principal, teachers, things like that. That really everyone has to be on the same page. So that includes the school nurses themselves. But fortunately nowadays, with kids, they're pretty independent in school, and that, anyone can just go and put $1 in a vending machine and get like, either potato chips or even a bottle of soda, like Coke or Pepsi or something like that. So, like, I feel like, obviously, like, as you said, tailoring everyone's goal to that patient. So obviously, like, we know a lot more about genetics, obesity, diabetes right now. So obviously, like, every patient is different. So, the actual hemoglobin A1C, which is used to measure diabetes, but obviously it's hard to really, focus, and it's hard to really predict at what weight, like, if someone will develop diabetes. So for one child, it could be, 150 pounds. I have a lot of children who are even like 250, 300 pounds, and they don't have diabetes. So, and we have, like, children obviously a lot less than that who have diabetes because of the strong family history. So I think it's really to tailor each patient and each child's goal, as well as, like, getting a good family history as well. And it's not just in terms of diabetes, but other comorbidities or other problems of obesity, whether it's high cholesterol, even fatty liver. A lot of, like, teenage girls with weight gain have irregular periods called polycystic ovaries. So a lot of times that's associated with diabetes as well. So, someone really doesn't have to have diabetes, but they can have some of the other complications, whether it's fatty liver, high cholesterol, like, things like that. And we also have to rule out other metabolic disorders. Someone may have a small thyroid, like, which can impact their metabolism. So I think kind of doing blood work, evaluating not just for diabetes, but for all the other complications, and then to kind of tailor the goals to each individual patient is probably the ideal thing. I think, like, that, like, they've actually seen that now. sometimes it could be genetic because, like, but we have found that over 95% of patients with PCOD are actually obese. So a lot of times, I mean, like, there is a very milder form called a thin PCOS where, so someone can have PCOD without being obese, but that's actually like, less than 5% of cases. Most times, like, someone who sees either an endocrinologist or even an OB-GYN with PCOD before starting hormonal treatment or even like, Ozempic or even metformin, the first thing the doctor will actually do is try lifestyle first before jumping on medication. So I've actually found that, especially with the complications of PCOD, which can include full-blown diabetes and even problems with pregnancy, infertility, things like that, I've actually seen a lot of girls who can reverse the weight loss naturally and they end up conceiving. So, it doesn't mean that every girl with PCOD has to be on medication, but they do have to have that willingness to lose weight. And I've actually seen girls who lose weight naturally end up conceiving without any problems. Exactly, it's not. So a lot of times, like, we try lifestyle for about 3 to 6 months to kind of see how they can lose weight. And it's definitely harder this time of the year, especially with the holidays. We're in September and then the weather's obviously getting colder. So I feel like, this time of the year, people are going to be indoors more compared to, say, June, July. And then especially this time of the year with Thanksgiving and Christmas, people are obviously eating more food with the families and things like that. So we do tell people to try to go outside more, eat healthy. And we say a gradual thing, especially with children. A lot of times people have unrealistic goals. So we tell them you don't have to lose 20 pounds in 1 month, as long as 1 or 2 pounds gradually, just and a lot of times with kids, we talk about the BMI, which is the height to weight ratio. So because they're going to get taller, even if they maintain the weight or even lose 1 or 2 pounds, they're going to kind of grow into their height.